That's what I'll do. Just move slow. Relaxed.
Okay, good morning, everyone. We're just going to give everyone a moment or two to log on, and we'll begin shortly. Good morning, everyone. Thank you so much for joining us today. We are so pleased to present the Weill Cornell Medicine and New York Presbyterian Kidney and Pancreas Transplant Program Conversations with Cornell Kidney. This is a virtual education series for patients, caregivers, and our transplant community. For Conversation 7, we will discuss social work and transplant caregiver resources. Our speakers today are Laura Bell and Melanie Conti. It is now my pleasure to turn things over to them.
Hi, I'm Melanie, and this is Laura. We're both social workers here with the Cornell Kidney Pancreas Transplant Program. I have been with Cornell for 6 or 7-ish years at this point. I used to work in the hospital for most of that time. I've been with kidney and pancreas for about a year now. I got my master's from Stony Brook, and Laura, I think, has been here since
2019. Got my undergrad from Stony Brook, ironically. We didn't know that till we met. But my master's is from Hunter, since all Hunter School of Social Work, since all social workers in kidney pancreas transplant have to be mastered and licensed. So we also then took licensure testing through New York State.
Yeah, in order to be a licensed social worker, you have to have a master's degree, which then allows you to take the licensing exam. Kind of the role that we play here with the transplant team is we make sure somebody is safe and appropriate in their social, mental, psychological status to have a kidney or pancreas transplant and be successful with it. We collaborate very closely with psychiatry. We're kind of typically the first line to psychiatry. And we're the only discipline that's not a doctor that cannot be overruled in selection. So in order to be cleared, you have to be cleared by a surgeon, a nephrologist, and a social worker. We take all the disciplines into account, obviously, when we're discussing, but those are the 3 that cannot be vetoed.
I just want to add that basically any patient trying to get on the transplant list is going through what is considered a biopsychosocial evaluation process.
What we're looking for when we're assessing candidates as social workers is that they have adequate social support, they have a good knowledge base, or at least a basic knowledge base of the transplant process, and their medical situation and how their lifestyle and or medical situation plays into their kidney loss, or how to care for themselves appropriately, and their access to care, which can range anywhere from insurance to transportation to having a support person to be able to help them navigate the healthcare system. Things we kind of assist with are addressing social issues. We will often sometimes bring to light things people don't realize are issues. And what we'll do is link people with different programs and services. We don't do things for people, but we help to empower people and educate people on the different resources and programs that can help them and explain how to navigate those systems. We also provide emotional support for patients and families. We can't do it on an ongoing basis. If we felt that someone needed more support, we would help refer them out to a therapist, but we are definitely there for any emergency situations or to talk through and process how someone's feeling.
So in a nutshell, we're essentially assessing our patients from the first time we meet them until we never see them again, always assessing for concerns and issues and barriers and challenges and struggles and positive things as well, providing a lot of education and a lot of support and resources.
So things we expect from a transplant candidate or things we're looking for, they must have a minimum of 2 caregivers. That's someone who can provide support and care throughout the transplant process. It can be emotionally, it can be physically. The level of care that a caregiver has to provide is determined case by case. It really is strongly based on someone's functional level, somewhat based on age, but almost wholly on their functional level physically and mentally. A home attendant cannot be considered a home health aide. It's a plus, and it's definitely something that is helpful and is a positive. But they cannot be, they can't make decisions for a patient. They really can't touch medications. And they also often like switch in and out on different days. So we're looking for somebody that's consistently in that person's life that would be able to have the most up-to-date information on them. Um, Recipients do need to be accompanied by not even a caregiver, a loved one, or somebody that is, involved in their care and knows what's going on with them for the first 2 to 3 weeks after surgery, depending on how they're doing and how much help they need at the time.
Yeah, I just want to add that it's about having people in your life that know you mentally and emotionally, that are going to pick up on changes if there are negative changes. Specifically, would be our concern, and somebody that's going to be ready, willing, and able to do whatever it takes to stay safe and keep the kidney safe. Um, if the patient's going through some rejection, through infection, is overwhelmed, it's just better to have people ready to support you through that.
A caregiver can be many different things. For transplant patients, a caregiver can be the difference between a successful and an unsuccessful transplant. Caregivers can be make or break. We often have patients who will look at their chart and read it and be like, this person doesn't seem like they would really be a suitable candidate. And then we go in the room and they've got family with them. And that changes the situation completely. Somebody who, we've transplanted people who are developmentally delayed, people who've had strokes, people with no legs, and by themselves, they probably couldn't handle what comes with a transplant, at least safely. And we would be putting them at risk by giving them the surgery. But if they live with their parents and their brother and they have all of this support around them, it really changes the picture. And we know that the person will be well taken care of and we can get them transplanted. Things that a caregiver should be available for could range depending on the person's situation, but they should be able to meet with the medical team either after transplant or while the person's in the hospital, assist them with things around the house, or maybe even bathing and dressing if the person needs it. Usually people feel better after transplant, but sometimes it takes people a longer time to recover. Definitely looking for assistance with medication management. Even if your loved one is completely on point, we definitely encourage you checking in and saying, hey, you remember to take your medicines today? Did you check your pill box? Daily hydration, again, just reminding them, like, how much water did you drink today? Did you drink enough water? And if they need it, assistance with transportation, like getting back and forth to the appointments.
I just like to emphasize that the medication and hydration, those are lifelong. And so anyone in a patient's life, those caregivers can change. Whoever's in your life, throughout your life, with your kidney, should be invited and encouraged to stay on top of you and assist you with the medications and hydration.
They should be able to help with coming to clinic appointments, like we said, especially in the beginning. It's a lot of information. There's a lot of changes in those first couple months, and it's always helpful to have a second set of ears. Definitely being available during any type of emergency. A big one that we sometimes find barriers with, less pets, but more so child care. It's very important that if you have a young child who's not, independent and requires either supervision or help, same thing with a dependent, whether that be someone with special needs or a parent, that you have backup care for that person, even if it's in case of an emergency, even outside of the 3 months, that you have a backup plan for who is going to be helping that person that you are caregiving for. Awareness of their emotional or mental health concerns, knowing the person's baseline, knowing what they normally act like, knowing if they're acting off. And we prefer, although we know it's not always feasible, but some type of flexibility with their work schedule. FMLA, I learned yesterday, is a federal program, not a state program. And it basically allows for job security. I believe it's 3 months or up to 3 months, where they are not allowed to deny you having that time off to care for a loved one. Some employers offer a percentage of your salary while you're doing that, 60%, 80%. That is not required as part of the act, but what is required is that you are allowed to take that time off and your job is held during that time. We're happy to fill out paperwork for that. We'll facilitate the doctors filling out paperwork for that. If it's something you need, we can provide letters for work. We can do any of those things. But, we encourage patients and their families to talk to their employers about the situation so they're aware and ready if things do come up.
Yeah, in transplant world, we always fill, the medical staff automatically fills the FMLA paperwork for 3 months because we know that 3 months is typically the really difficult part of recovering with your new transplant and where things are more delicate and time sensitive. Back to the um, pet care part, it is something that just in childcare part, pet care, childcare, something to be aware of right off the jump is that after you receive your new kidney, you're automatically in the hospital for a minimum of 4 days just to start. And then that doesn't factor in if there is or are some readmissions, which are not always, but sometimes they do occur.
One of the other more rare things, like I'd say the most hands-on care a caregiver might have to give could be IV antibiotics. Sometimes because our patients are at such high risk for infection, they require IV antibiotics. And often it can be done, or it has to be done at home because insurances will know it can be done at home. So they won't pay for it in the hospital if it's a long duration. We teach the person how to do it before they leave the hospital. There's someone that comes in and teaches them again in the house. But it is not a service that insurance covers for a nurse to come to your house every day, 2 or 3 times a day. So a caregiver would have to be able to, or willing to, learn how to do that. And then sometimes wound care, not as often. A nurse usually will come in like 2 days a week and help with it and reteach how to do it. But usually the actual care, most of it falls on the family or the patient. But those are probably the two most involved things that caregivers would have to do. Other requirements would be the ability to, or preferred requirements would be the ability to ambulate a minimum of 1/2 of a city block. The more mobile you are, the better it is for you. The easier recovery is going to be. The complications go down by a lot, or the chance for them go down by a lot. Wheelchair dependent patients are assessed on a case by case basis. The absolute minimum requirement is that you have to be able to transfer from whatever you're sitting in, may that be a wheelchair, into another chair independently, or at most with maybe a hand not lifted. This is because sometimes patients require something called delayed graft function, which is temporary dialysis to wake a kidney up afterwards. And the dialysis center we partner with across the street, that is a requirement for a patient to get dialysis there. So you have to be able to transfer independently. That could include a transfer board. We just cleared someone recently that has no limbs and transfers with a transfer board, but you can't require the assistance of somebody else to get in and out of the chair.
And I'd just like to add that, being able to walk, the further you can walk before surgery is always better, especially in the event that there's a complication. If you already have limited mobility, you could end up with no mobility. In kidney transplant world, this can be actually not an improvement in the quality of your life, because if you're not able to get to the restroom in time and you go from very limited urine output to no urine, maybe you had no urine output to now um, urine output that's regular, yet your bladder has shrunk while you were on dialysis. You could end up with skin concerns, bed sores. It could be just a worse situation. So these are things that we consider, and we help our patients to consider. So taking an extra step every day in preparation is always my advice.
Our patients have to be show us that they are compliant with their medical care, their medical treatments, their medications. If we see or reported a history of noncompliance, depending on the severity, the patient may have to demonstrate a period of time where they have been compliant. It really ranges a lot based on situation. If we have somebody who we saw left in ER AMA because they were there for 6 hours and it was a year ago, that's just going to be a conversation. If we see somebody that's been to the hospital 6 times in the last 5 months and they've left AMA every single time, and all of the chart notes that we can read say that they don't always take their medicine or follow their doctor's advice, we would probably require for listing 6 months to a year of compliance. It's very important because you have to take your transplant medications for the life of the kidney and hopefully for the rest of the patient's life, depending on how old they are. Every day, twice a day at the same time or close to the same time every day. We know everyone's human. If you forget to take your meds every once in a while, like that's not going to preclude you. But that's part of what we do is help find ways to fix things like that. If we get a patient who says, "Oh, I forget my meds multiple times a week," well, you can suggest getting a pill box. Why don't you set an alarm on your phone? This is how you can do it. If they have a caregiver that's close with them, we could talk to that caregiver and ask them to call their loved one a few times a day and remind them to take their medicine. So that kind of shows how we try to mitigate these things. And they also have to have a basic understanding of their medical issues, the transplant process. This again, if they have a very strong caregiver support and someone that's strongly involved in their life, then if that person has a very good understanding and is able to basically manage all their medical needs, that would also suffice.
Yeah, it's our approach here is really to assess, find these challenges, these barriers, and work as hard as we can with the patients. Obviously, we have limited capacity. It is an outpatient setting, but try to figure out a way to get somebody to where they are ready to receive a transplanted kidney and or pancreas. So again, caregivers come into play quite often if somebody is pretty dependent. The caregiver can be the solution, and that's when we would typically maybe even ask for more than just two if somebody is very dependent to start.
Eliza, I don't know if I'm wrong about this. I saw someone raise their hand. I think they can write their questions in the chat. Is that what they can do? Because at the end we'll address them. Is that right?
Yeah. Hey, oh, sorry. I just raised my hand. So, at the bottom, there's a Q&A box, and it actually looks like someone has put in a question. So, as opposed to just raising your hand, if you can type it in, it would be easier for us to keep track. Thanks, Mel.
Oh, what you do? You broke it, Laura. Okay, fix it. Substance abuse, pretty hard line on substance abuse, especially addiction. Actually, yeah, addiction. Drugs that are legal, alcohol, you can drink before kidney transplant and after. You can use marijuana. We're looking for people that are drinking a pint of vodka every day, need a drink in the morning, multiple failed rehabs, marijuana.
Any dysfunctional
Yes.
use and or abuse is a concern.
Yes. Marijuana, it's important to know that if you use marijuana, it can affect the levels of, I believe, Tacro, one of the transplant medications in your system. So people who use marijuana have to be very communicative with their post-operative team about how often they are using it so that we can do lab work more often and make sure their levels are okay. Everyone who uses marijuana has to see a psychiatrist in order to be clear, just to make sure there are no dependency issues or functional issues because of it.
Also to educate you on how the marijuana can interfere with the successful kidney transplant.
Yes. Illicit drugs, pretty hard line. I would say, if someone told me they used cocaine a few times a year, we would just recommend to stop using cocaine. But somebody who is using cocaine every day, multiple times a day,
or dysfunctional use.
Any drug at all, honestly, dysfunctional use of any drug would likely require some type of substance abuse program, whether that be AA, inpatient rehab, outpatient rehab, intensive outpatient program, psychiatric or psychological specialized care, usually for 6 months to a year, depending on the severity of the abuse or dependency.
And some health insurances require us to do tox screens and some do not. And then if we have concerns, we can also require them.
Hey, ladies, just one question. I think someone's having a little hard time hearing you. So if you can just be just a tad bit louder, we'd really appreciate it. Thank you.
Yeah. Mental health. We transplant patients with treated mental health disorders, untreated mental health disorders. What we're looking for is if their mental health disorder is impinging, what's that word? On their life, their ability to function. Do they get so depressed that they stop taking their medications? Are they so paranoid that they don't trust their doctors and don't follow their advice? Eating disorders, very hard to treat, very tricky disorder, but even more so serious with transplant because proper nutrition after transplant is very, very important. Bulimia, throwing up your medicines. We've had patients whose eating disorders have reoccurred and they have a vast amount of complications, end up on artificial nutrition. It's extremely important to have proper nutrition after your surgery. So all of these kind of things we're looking for. If we feel somebody has a mental disorder that would harm them after their transplant or prevent them from being successful with their transplant, we will often require some type of mental health linkage, and depending on the severity, sometimes require a certain length of time of treatment, and then check in with those treatment providers to make sure that they think the person is doing well enough to be successful and safe with transplant.
And I'd just like to emphasize that some patients lose appetite post-transplant for a variety of different medical reasons. So again, having a eating disorder prior is it's something that really needs to be stable. And then if there is any reoccurrence of any mental health conditions, diagnoses, there is always access to social work and psychiatry on the post side. Obviously, it's also part of what we do on the pre side, but it's also what we do on the post side.
Housing's another factor that plays into someone's safety and suitability for transplant. Your house must be safe. It must be stable, no structural issues, infestations, hoarding, just an unclean living environment. You have to have access to running water, heat, electricity. You cannot be at risk for eviction. And even if you are 1 month behind on your rent, that does count as being at risk for eviction because 1 month can turn to 3, which can turn to 6, which can turn to a year. What we do typically try to do with patients like this is we get them connected to something called NILAG. It is a free legal assistance group that can help with navigating housing issues and usually working out some type of payment plan or some forgiveness for the back pay. There's also one-shot deal, which we educate patients to, which basically the city has a program that they will often pay off a large sum of rent. And depending on the person's situation, they may have to pay it back as a loan, or if their financial situation qualifies for it, they wouldn't pay it back. You do have to show how you would prevent becoming back in that situation again. Sometimes, unfortunately, our recommendation is for the person to move into a more affordable living situation. Shelters, we cannot transplant patients that are in shelters. They are too dangerous. They are not clean. They are crowded. We would definitely be putting somebody at risk for harm, doing more harm than good if we transplanted someone in a shelter. I should preface this, there's 2 ways to list. There's active and inactive, status 1 and status 7. Status 1 means you are on the list, you are accruing time, and when your time comes, you will get a phone call for a kidney when we find a match. Status 7 means you are on the list, you are accruing time, and you cannot get phone calls, you cannot get offers. This usually doesn't make much of a difference because we see people quite early on. It really usually only affects people with living donors or people that have come in when they've already been on dialysis for a very long time. usually we have several years where the person wouldn't be getting a phone call anyway, and we're able to mitigate these issues and get them cleared for active listing before they would ever get a phone call. We with situations like this, shelter, housing situations, we will often list status 7. And that's what we're talking about when we're saying like someone would need mental health therapy for a few months or compliance for a few months. We will typically list them status 7, inactive, while we mitigate the issues and try to resolve whatever it is. Nursing facilities, also very dirty, very, unfortunately, there's cares there. It's not that good. It's not very responsive. And again,
Just too many people.
yeah, too crowded. Even, simple as infection risk, you're going to be, your immune system's basically nothing, and putting you in a place that's known for people contracting infections. Urination, most people on dialysis, their bladders shrink, so they have to go to the bathroom extremely frequently after they get a transplant. And anyone who's been in a nursing facility knows it can take hours to get someone in your room to help clean you up. People in nursing facilities tend to usually have a lower functional level, so they wouldn't be able to get up and go to the bathroom themselves in most cases. So all of these things are things we would not be able to clear somebody for.
To rule out until the person is more biopsychosocially ready. So that includes, having a safe home to return to, super important. Now, that doesn't mean that if there is a complication post-transplant that we would not access a rehab center. We prefer to access the one in our hospital, but that's acute. So that means that the person is only decompensated a little bit and can tolerate 3 hours of physical therapy per day.
Short stay,
short
maybe
stay.
2 weeks, but usually 5 to 10 days.
But we feel safe with that one because we can literally, the team can see you every day there. But if necessary, if there is unforeseen more extreme complications, we would access a rehab if medically necessary and worth the risk of putting you there, because the risk of you going home is worse in that moment.
But that's part of why we assess caregivers and functional status so carefully, because like Laura said, if we have to and it's the safest thing, we will do it. But we would never clear somebody whose plan was to go to rehab after transplant. We're looking to mitigate that. In fact, I was on a phone call with someone yesterday whose family right now, their 3 daughters are trading off, taking 24/7 care for him, even though I think more than one of them, I know the one I spoke to lives out of state. Simply to try to get him, they want to avoid a nursing facility in general, but they are going to do this for the next month and a half just to get him through the first 3 months, so that if they do need to put him in a nursing facility for rehab, they will after his immune system is back up and functional. So it's really discouraged. It's something the team really does not like to do. And again, it's because we're putting the person at risk by doing that. So we'll only do it if it is a last resort.
I guess a big part of what we're educating, or what we're doing in our assessment process, and what we're educating to is, weighing the risks and the risk, the benefit constantly.
Because kidney transplant is an elective surgery. So we always want to make sure we're going to be improving the person's life and not worsening in it, not hurting them or endangering them or doing anything like that. Because someone can live their life on dialysis. It's not pleasant and it's certainly not ideal, but they're safe. And we don't want to be doing something to them that's going to then put them in a worse situation than they were on dialysis. Legal issues. Right now, we cannot clear anyone who's on probation or parole. It's the same reason again. Crowded, dangerous, dirty, pretty hard access. I forgot this. Nursing facilities also are notoriously bad at getting people to appointments. I would imagine prison would be bad at getting people to appointments too. You have to be here 2 to 3 times a week for 4 to 6 weeks, and once a week for 4 to 6 weeks after that, after transplant. So it would not be likely that the person would be able to access the follow-up care and be in a safe, clean environment that they need to properly recover from the surgery. Another thing that plays into legal issues is immigration. We cannot clear anyone who is not here legally active legal status. So that includes people that residency has expired. Sometimes even because there is such a huge backlog on the residency permits and renewals, if somebody is like 3 months away from their residency expiring and they haven't even started the reapplying process, we would put them status 7 because it's taking about 2 years right now for them to process through these renewals. So anybody who has here with for residency, like their status as being a U.S. resident, not a citizen, we strongly encourage them to apply even a year, restart the process even a year early, whenever they're allowed to start the process to renew it, do it then. They are giving out letters saying that they're extending it. You know, like once you do the reapply, they'll say they're backlogged and they'll extend it out 2 years. But I have patients right now who have that letter and it's past 2 years, and I cannot put them active on the list right now because we're still waiting for their residency to be rectified. Financial and the probation and parole is because you're at high risk for reincarceration. I should have led with that. Financial stability, we're looking for basically that they have either the finances or are enrolled in public assistance programs that allow them to access their basic needs, whether that be food stamps or money. We're looking that you can pay your bills, you can pay your rent, you can pay for food and necessities. And then the last one, which is the hardest one to address, is copays. So somebody who's already having difficulty affording their medications, it's likely that transplant medications cost more money than what they're taking. What we'll try to do is link them with, if they're not already enrolled in certain public assistance programs like heating and energy assistance, there's Wi-Fi assistance, there's cash assistance. I think that one's harder to get. There are rental assistance programs. They are very difficult. The wait list is very long. Food pantries, delivery programs. There's a lot of different things, food stamps, that we can try to get people linked with or have them apply for, which can help, offset the cost of their daily living and then hopefully allow more money for their copays. And then the only other thing, there's GoodRx, there's websites like that. And I think some very rich guy started a website. The medications are limited on it. We're hoping in the future more medicines will be on it, but those are kind of hit or miss. There usually isn't that big of a difference in cost. The only thing that tends to work is if the person financially qualifies for it, it's prescription assistance. Yes, yeah. Prescription.
Sometimes, but they're few and far between. So in the pre-process, we really spend a lot of time making sure that patients have income, and whether that's working and being on Social Security disability, or just being on Social Security disability, or if they qualify for Social Security due to age or Social Security income due to illness. And then in some of those situations, they also qualify for the food stamps. And in New York, those programs are pretty good. But if somebody doesn't qualify for those things, it can be a rule out.
Another thing we often will do, I've had patients who, were reluctant to ask their families for financial assistance, but had families that could financially assist them. So it's not ideal. And we will usually encourage somebody to at least get SSI or any type of thing they qualify for. But if they live with their family and their family is able to financially support them, or even if they don't and their family can pay their rent or help with paying for their food, that is also sufficient as well. As long as that person can commit to do that, indefinitely. Back to pets, what we're looking for in terms of pet care is that somebody can basically clean up after the pet for the 3 months after surgery. You shouldn't be picking up animal waste after your surgery for 3 months. Plants, we don't really talk about, but you're not really supposed to be like watering your plants and definitely not messing with the dirt in the plants. So
no gardening.
Yeah, no gardening.
3 months.
So having someone who can help you take care of your plants, or even ideally if they could take the plants to their house for 3 months, that would be the perfect situation. It is fine to have your pet. We encourage people having pets. It's fine to pet your pet and spend time with your pet. It's just cleaning up after the pet. That includes birds, that includes fish. No cleaning bird cages or fish tanks. No changing diapers of babies, things like that.
Yeah, babies similar to pet waste and soil products.
We talked about this a little before. Post-transplant follow-up visits, a person has to be able to attend clinic 2 to 3 times a week for 4 to 6 weeks, and then once a week for 4 to 6 weeks after that. I believe the milestone visits after that are once a month for 3 or 4 months, then every 6 months for like 2 times, and then once a year after that, something similar to that. You cannot take public transportation for those first 3 months. Mass public transportation, Access-a-Ride is fine. Medicaid cab is fine. Regular taxis are fine. No buses, trains, subways, ferries. We can't do mass public transportation. Patients can't drive for 3 to 6 weeks. We advise them to prepare to not be able to drive for 3 months. But most patients without complications will be cleared once their incision is healed, and that's at about 3 to 6 weeks. Access-a-Ride is offered within the 5 boroughs. Anyone who has Medicaid, at least in New York, and I believe New Jersey and Connecticut as well, are entitled to transportation through their insurance.
Up to 99 miles.
Yes, some insurances will cover it outside of it, but in those cases, we have to have the patient call their insurance and verify. Outside of state, we also ask patients to verify that they will cover it. Most Medicaids will, but it's important to double check. And then if you live outside the 5 boroughs and you do not have Medicaid, there really is no other options available. Technically, there are services like SCAT or the Nassau version. I think it's called Scout or Scoot.
But they don't necessarily bring you all the way here.
They won't bring you here. The only
is
way to do it, New Jersey has one, you'd have to go from the point in New Jersey to a drop-off point, get picked up if the Access-a-Ride
get
goes
picked
there.
up.
It's not really feasible, especially because all these services do not run on time.
Especially if you're having a difficult recovery period, it's not advisable. So this is where caregivers again become crucial. And this is also an area where many patients are advised and end up, besides the 2 caregivers, maybe also have a separate list of potential drivers that can get on a rotation, especially if somebody needs to come 2 to 3 times a week initially. And then some patients, if they have means, are encouraged to find local housing, either hotel, Airbnb, ARBO, any of those are acceptable. You can tell that they're clean via the websites.
You also can, if you can afford it, you're absolutely welcome to take private car service or a taxi to and from clinic. We just are well aware that that's not affordable to most people. Another way around this too is if you know anyone that lives in the 5, if you don't have Medicaid, if you have any family or friends that live in the 5 boroughs, you can sign up through Access-a-Ride with their address. And if you stay with them, they will pick you up from that address and bring you back and forth to your clinic appointments, but it has to be in the 5 boroughs. It does go slightly into Nassau County, but it's, I think, 2 or 3 miles into Nassau County or something like that.
I want to add, if you live 3 hours or more away, it's actually a requirement that you give us a local address of where you're going to be staying for your recovery period and expect to stay up to 3 months. I have seen it occur 1 or 2 times where somebody ended up needing to stay longer, but typically it's 3 months and maybe even a little less.
We also do not have any partnerships or deals with local hotels or anything like that. We do have the Helmsley, which we have a partnership with across the street. It's cheap for New York, but it's still $200 to $300 a night.
It's huge for New York.
It is. It's very
Studio
large.
size.
You can write it off in your taxes. Not the tax. I don't know if they tax you or they don't tax you. If they
don't tax you if you have hospital discharge paperwork.
Okay. So it's tax free as long as you show them that you're, getting care here.
And it has kitchenette large enough to control your food intake and preparation during your recovery, which is advisable by our dietitian.
The only other resource we know about for adults is Friendship House, but that is part of the Jewish community, and you usually have to be linked with a program called Renewal to get access to it. Renewal is, again, a Jewish agency that helps with finding people within the community donors. But Friendship House would be the only other thing that we know about. If you are a child, which I don't think any pediatric patients are attending this, but if they were, there is Ronald McDonald's House, but that is only for children. This part's just let us know if anything changes. We need to know if you move. We need to know if your phone number changes. We definitely need to know if your caregiver's phone number changes. Is there a change in your caregiver plan? Did something happen to one of your caregivers? Can they not provide that care anymore? If your transportation plan changes, if you got a job and you lost your Medicaid, we need to know that.
Especially if your transportation plan is connected to your Medicaid.
Yes, well, yes. Again, they all kind of link to if your caregiver, something happened to your caregiver and they were your ride, that changes things. If you were clean and you are now not clean anymore, we need to know that. So
As in substances.
Substance abuse, yes. I'm concerned about the ability. If you have reasons why you think you no longer would be able to meet the requirements and things that you need to do to keep you safe after transplant, any changes to your memory or ability to think. And again, this can be communicated by the patient or their caregivers, and it can be communicated to ourselves, your coordinator, anybody on the team.
This is actually a point I like to emphasize why the caregivers are so important. If there are changes in cognitive functioning, memory, or thought process that are negative changes, declines, you may not realize that that's happening. And so having loved ones, aka caregivers in our world, that can support you with that and inform us so that we can have you tested and make sure you're safe for surgery.
And the other thing would be insurance, which can affect anything, your ability to get meds. Can you even get surgery here? Can your donor get surgery here? Can you get your medications? So we definitely need to know about any insurance changes. These are just different resources. The number to Access-a-Ride. We have the access to Link Paratransit in New Jersey, but the only reason I could think that would be valid would be like if you took it to somebody's house in New Jersey that was going to drive you, it wouldn't really be helpful in any other situation. Social Security contact information, that's SSI, SSD, and regular Social Security.
I think I put the Access-a-Ride Paratransit New Jersey because some patients, maybe they have some money, but not a lot of extra money. So they could take their Access-a-Ride to the border and then jump in an Uber.
Oh, yeah, that's true. You could do that too, yes. Medicare information, you do qualify for Medicare automatically after a transplant. It usually takes 3 to 5 months to hear from them and apply for it. And then being on dialysis, you also qualify after 3 months. Medicaid phone number, that's for New York, I believe. Food stamps, DSS, HRA, HEAP. DSS kind of handles all of these programs. It's an umbrella agency. I don't think we put it on here, but 311 is actually extremely helpful and I feel like underutilized. So if you ever have questions about anything, 311 can get you almost anywhere. They're wonderful. They helped me the other day.
You can even call them if your car disappears and you're not sure if it was stolen or towed. You can call 311 and they'll let you know if it's been towed. They'll let you know parking rules for the day, etc.
Yeah, great. Support services, support things. Transplant mentorship program. If you are a patient who has already had a transplant, they are always looking for new mentors. Otherwise, if you haven't had one yet, what they're doing is pairing you with someone that's been through the process before. A lot of our patients find it very helpful. They really like that program. New York City Well is a program for mental health. NAMI is a program for mental health, smoking cessation.
Maybe just emphasize NYC Well is for anyone in the 5 boroughs. NAMI is for anyone nationally. These are good for anyone that you're concerned about in your life, yourself or anyone else, even a neighbor that you don't actually know that much about. If you see has some concerning behaviors that are life-threatening to them or others, call either one of those lines. And the mentorship program, just FYI, it's phone calls. It's flexible. It's not a strict program, and it's anyone who's a mentor has a little bit of training and has had a successful transplanted organ for over a year.
We also have our transplant support group that Laura runs. It is the second
Wednesday of every month at 10 a.m. Very flexible, very free flowing. please join. There's no rules. You don't have to be seen on screen. It's virtual. It's flexible in terms of that. You don't have to talk if you don't feel comfortable. If there's a topic you want to throw out or several, please, we're open. We may table that topic, and if it's something I need to do a little research on until a later discussion, or maybe other people in the support group already have information or expertise. And another really beautiful thing that has happened organically with this support group so far is that there is always at least one person that's joining us so far that has had a transplant or two at this point, and are very helpful for me and for the other people participating.
Transplant resources, National Organization American Kidney Fund has a lot of great programs, especially before transplant, actually, for financial assistance. The major one being that we often see is they can help with insurance premiums, particularly Medicare premiums. And they will sometimes help, depending on the person's situation, for a short period of time after transplant. The rest of them are more just like supports, a lot of educational material, a lot of statistics and information, and just ways to find more information about kidney transplant. We also have our own website, which of course contains all of these things and probably has links to all of these resources as well.
Just want to emphasize, UNOS is the United Network of Organ Sharing. They are the people that manage, oversee all transplanted organs nationally. That's whose list we are all working with in this country. And so they dictate all the rules. They make sure that everything is fair, and they let us know as people are moving up closer to their date of transplant.
Microsite program. There is also, I don't think we have it on here, Rogosin also offers this online support group.
The Rogosin, if you're
Yeah.
connected with them, it's probably open even if you're not connected to them, but the Rogosin does have a support group. And actually, if you're really interested, there's a third organization that runs support groups in the boroughs and outside in the whole New York region. So if you're interested in other options besides the one listed, just get in touch with Melanie or myself.
Microsite is basically online dating meets kidney lottery. You make a website about yourself, why you're looking for a kidney, and your story. This is a way to try to find living donors when you don't have one available to you. The way we see success with it is the microsite will give you a link to your personal website, and they also give you like a bunch of little business cards. 250 little business cards. So we tell people, put the link on your social media, tell your friends to put it on their social media, give everyone you know a card and give them 6 other cards and tell them to give it to everyone they know. Sorry. Tell them to give it to everyone they know. We had a man once whose dad put a sign on his lawn, and the dad's neighbor gave the patient a kidney. So it's basically how you market it, and that's how we see success with it.
And the great thing about it is once you have it on your social media, your link to your site, you never know how far it can go. And if somebody does take interest in giving you a kidney, they just can click on the link and the process gets started without you even knowing sometimes. Well, unless they tell you, you wouldn't even know.
There's different ways to connect with us. We are on all the different social media websites, Instagram, Facebook, YouTube, Twitter. Cornell Kidney Transplant Program has their own handle. And I'm sorry, has their own handle at WCM Kidney. And you can find us on all these, and this QR code, I believe, would take you to them. And these are our upcoming next webinars. September 26th and 27th is Understanding Finance, is probably more in-depth information about insurance. And October 24th and 25th is just information about the pancreas transplantation, kidney and pancreas.
And I do want to add that there have been conversations with Cornell Kidney. We've been doing this, our colleagues started this back in the beginning of the year. There is already pre-recorded conversations with Cornell Kidney, several of them. You can go back and watch them, and you can continue to watch the future ones live and or recorded by signing up.
I think that's the end.
That's
Yep,
it.
that's the
Questions?
questions.
Thanks, guys. Yeah, we have quite a few questions. So I'll just read them off to you. So when you say the caregiver may have to be trained to give antibiotics, do you mean intravenously? Yes.
IV, yep. It's often a better option. Even, Melanie mentioned that insurances sometimes won't pay for it,
They never.
but there's a deeper reason for that, and it's actually doesn't make sense to keep somebody in a hospital for an extended time if they can be treated at home with the IV antibiotics, especially if they're so immune suppressed. It's a win-win. You don't want to be stuck in a hospital with so many different people if you don't need to be.
It's not, I think people get scared hearing about it because they think they're injecting their loved one. That's not if someone needs this treatment, they have a line that's semi-permanent, it's not permanent, it's a long-term line, which has little lumens, little things at the end of it, and you put the medication into that, and it's usually either a drip bag or these little high-tech ball things, depending on the insurance and the medication. So you're not injecting your loved one every day, multiple times a day, or using the line.
It's made very, very simple for
I had
people of
patients do
all
it
different
themselves.
IQs.
Yeah. They have extensions, patient can do it themselves. This is more like if your loved one wasn't able to do this. They have arthritis, they mentally wouldn't be able to understand it, that kind of thing. But I've had many patients do it themselves.
Awesome. Yes, it's a learned skill. If you were previously addicted to painkillers, would you have to take prescribed painkillers after the transplant? That's a really good question.
It's more a question for the doctors, but I know
Yeah.
after your transplant, you're usually on something called a PCA overnight. The next day, they discontinue that for almost all patients, and they would switch you to oral narcotics. Most of our patients, by the time they leave the hospital, are not on narcotics anymore, and it's very rare that we discharge with narcotics. If you don't want narcotics, they're not going to force you to take narcotics, but I'd say 99% of patients do not leave this hospital on narcotics.
99.9% probably.
Yeah, it's very rare. Very rare.
It's not advisable. Any other questions?
There is. Yes. Again, more
The
for the
question
doctors.
is, will
Oh,
the
yeah.
bladder begin
They
to
can
expand after successful transplant and continuous urination? Yes, 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 yes. But it's different for everyone how fast it will expand. It's also different for everyone how much it has shrunk prior.
Picking up always surgical gloves. We're supposed to tell you you can't do it. People that ask me this, I say ask the nephrologist. If the nephrologist says it's safe, you can do it. You're going to be assigned a nephrologist. That's the person you're going to be seeing most of the time in most of your clinic visits. If they think it's safe, it's fine. You can even ask them if you have to meet a nephrologist for your evaluation, and if you want to check with them.
I want to add, though, as a social worker that takes this serious, again, it's risks versus benefits. If you go home to a family of 7 people with 3 infants with runny noses or several toddlers that go in and out of preschool constantly, and you want to also go pick up after your 3 dogs, it's not wise. It's too risky, because then you also have to come to clinic 2 to 3 times a week. So it's about, if you go home to a perfectly clean home, 1 or 2 people or 1 person only, and you have 1 dog, and your nephrologist says, okay, it's okay, and you're not fighting infection, and there hasn't been any risk of rejection, so they're not continuing to keep your immune suppression at a tense level, then okay, maybe you get cleared. But I always say, let's err in the realm of caution and assume that if you're fighting an infection, it's not going to be advisable even with a glove.
Again, the plant question is more for the doctors. I wouldn't be able to explain to you exactly why. My guess is that when you water a plant, it probably knocks the dirt up into the air. I'm really not sure. A question for a doctor. But I just know, again, like if you have, I have like 300 plants. They're not denying people because they have plants. It's just things we try to avoid.
Yeah, I've never actually heard that. So
they told me this a few weeks ago when someone found out I had a lot of plants at my house.
You know what it is, guys? I'm not so sure about plants, but definitely flowers. When flowers are sitting in stagnant water, they did not allow flowers on 7 North for a long time.
Absolutely.
I
Okay.
don't know if they still do.
Okay, so
I
that
thought
makes
that was
sense.
allergies. Yeah, interesting. Yeah, I checked with the doctor. That's not that one. We don't even have that on the paper. It's just something one of the doctors brought up to me. I'd say last month when we were talking about how I have a lot of plants. They were like, "Well, you couldn't. You know, it'd be hard for you." But yeah, again, a lot of these things is like check with your doctor. We're told one thing hard and fast, but in reality, a lot of these things are like a spectrum, and the doctors are really the ones that can
It's-
tell you what is the actual level of risk.
It's a spectrum because it's a process, and everybody's in a different part of the journey. And while some person might have a new kidney, feel a million times better, have absolutely zero complications, be running marathons within 4 months. Somebody else may be fighting rejection, struggling with infection. So the rules are going to be more important. The restrictions, I should say.
No, you cannot go to a barber shop or hair shop within 3 months. I think that said in the 3 months, not after it,
No
right?
crowds or dirty places. I always say
No.
no crowds, no dirty, germy places for up to 3 months, except for here. The risk of not coming here outweighs the benefit of coming here and having your team being able to check on you mentally, emotionally, medically.
It's also not necessary. Like if you are going to the grocery store because you had no one that week and you go on off hours and it's because you had to get food and you had no other choice, we're not going to tell you you can't do that, but you can, it's all right. You're not going to be being that social the first 3 months anyway. So no, you cannot go get your haircut during the first 3 months.
Are there more questions?
I think that was all of them.
All right, we ended on time.
I think we did.
You guys got the bladder expansion question?
Yeah, we did. We answered that one.
Yes.
All right, everyone. Well, thank you all so much for joining us today. Thank you, Melanie and Laura, for your time and so much
I don't
wonderful.
know. I'm sorry. I don't know the answer to the last
Yeah,
one.
so the last
You'd have
question
to check yours with
is-
your surgeon.
The last question is, how soon can you have sex after transplant? As the social worker, the way I answer that is obviously how Melanie just said. You need to check in with your doctor. Again, everybody's journey is different. You're immune suppressed. If you're having trouble keeping your nutrition, like eating enough nutrition, and your incision is not healing, it's going to take much longer, right? If you're having a perfect recovery, incision is healing really fast, hopefully your doctor is going to clear you sooner
When the
than
doctor
later.
says so, that's when.
Yeah. Nephrologists.
I've actually heard a physician answer this question, and the surgeon said, when you feel up to it, you can do it.
All right, there we go.
Yeah.
All right. Well, thank you all again so much. We so appreciate your time. To all of our wonderful attendees, we thank you for your active participation and your wonderful questions. And we look forward to seeing everyone next month. Have a great day, everyone.
Bye, everyone.
Bye, thank you.
Bye-bye. Bye, thank